you very much for inviting me today. Pretty much act as it's, amongst other things, ME Awareness Week this week. And I'm here to talk about chronic fatigue syndrome, ME, and our service in Oxfordshire. So prior to coming today, I did speak with my GP friend, Jen, just to ask her, in her view, what might be interesting to know as a GP about chronic fatigue syndrome, ME. So we met up for a coffee. Actually, it turned into two coffees and a very large chocolate chip cookie. She had a very long list of questions, so I've attempted to sort of encapsulate them as much as possible within half an hour today, so I'll try and get through it quickly. So I'm Rachael Rogers. I'm clinical lead, and my new title is highly specialised CFS-ME practitioner, which actually causes chronic fatigue saying it. I've recently, in the last couple of years, taken on an extended scope practitioner role within the service since our gypsy retired a couple of years ago. But we are a very small community-based county-wide service within Oxford Health for both young people from the age of 14 and adults with CFS-ME. So there's myself in the team and two fellow CFS-ME clinicians, all of which we're all occupational therapists by background, and in total we make up 1.78 whole-time equivalents, so not very much to get around the county and the vast age group that we work with. But I've been very lucky to have been with the service since it started. We're now in our 15th year of operation, and we began as a Department of Health funded project, 2-year pilot project, to set up local MD teams around the UK, and fortunately we have continued to be in operation, whereas some counties have lost their specialist MDTs. So since our inception in 2005, we've seen the NICE guidelines come out in 2007. We've had a big PACE trial, which has had a lot of controversy attached to it, and we've got our new NICE guidelines coming out next year in 2020. At the moment, we're calling it chronic fatigue syndrome ME, but I believe next year, when the NICE guidelines come out, we'll be calling it ME-CFS, but I don't want to get caught up too much in the nomenclature of that. That's a whole other presentation. So, as you can see there, in terms of epidemiology, the NICE guidelines state it's quite a common condition. Within a practice of 10,000 patients, you're likely to see around 40 patients with the condition. And NICE highlight that actually the symptoms can be just as disabling as multiple sclerosis, lupus, rheumatoid arthritis, and other chronic conditions. I'll go on to talk about the wide range of symptoms that patients experience in a minute, but in terms of a little bit more on epidemiology, it's quite difficult to actually work out what the prevalence rates actually are, because there's so many diagnostic criteria for CFS-ME as well as so many different names. So the estimates are between 150,000 and 250,000 in the UK. It does affect all age groups, including children, and the ratio is usually 2:1 female to male, but in young people we find that it's more equable in terms of its predominance. It is actually quite rare for patients under 7 to be diagnosed with chronic fatigue syndrome, not unheard of, and I'm aware that UCLH have got a 5-year-old at the moment that they're working with. But also it's quite rare for those above 60 to be diagnosed with a new onset of chronic fatigue syndrome, ME. So I think my national colleagues tend to recommend, if this a new presentation over the age of 60, then maybe a review with gerontology might be appropriate. But the most common age of onset in young people is around sort of 13 to 15, so that time of GCSE options, heading towards those final 2 GCSE years. And then in adults of age 20 to 40. And it might interest you, that it's a bit old, but in 1996, Sheffield Hallam Uni predicted that the annual economic cost, that in terms of lost income, benefits and health, was around about £3.5 billion for this condition. No idea how much that compares to other conditions, but it is having an impact. So just very quickly, the symptoms, there's quite a vast range of symptoms, and I'm sure you've seen a lot of those in your CFSME patients, and certainly all of those that are coming to our clinic have some, if not all of those symptoms that they're experiencing to very different degrees. And in terms of diagnosis, as I'm sure you know, CFSME is clinically defined syndrome with a characteristic pattern of symptoms, but no consistent abnormalities on physical examination or lab testing. So I think that's why it's often referred to as a diagnosis by exclusion. I don't think it's helped by the fact that there are now over 20 diagnostic criteria for CFSME. Most of those are being used in research, but only a couple that are more sort of clinically relevant. But in practice, what we find is the symptomology is frequently consistent enough to allow a positive diagnosis of CFSME to be made. You're probably all aware of this, but this is the Fukuda criteria for CFSME, also known as the CDC criteria, which is the one that's most commonly used in clinical practice. As a service, we also use the Canadian clinical guidelines, which the patient groups tend to prefer. So we kind of sit on the fence a bit and use both of them at the moment. As you know, chronic fatigue is a symptom of so many conditions, and you'll probably have numerous patients presenting in your surgery with fatigue-type symptoms. And because it's a particularly difficult diagnosis to make, there are many other conditions which you might need to be ruling out before they head our way. So there's a number of autoimmune, infective, metabolic and neurological conditions that can often cause debilitating fatigue, and I've listed just some of them up there today, and I'm sorry it's a bit small, but hopefully you'll be able to see from your slides what they might be. And then what we require of you is some baseline investigations, if possible, bloods, which may help with some of those differential diagnoses. I'm aware that these are perhaps pretty standard, but there may be some more at your own discretion which you think may be relevant to screen for in terms of celiac, or vitamin D is another big one that we're experiencing in our clinics, vitamin D deficiency. So time scale for diagnosis, it's got pretty tight, which I appreciate in general practice is very difficult, especially if you're trying to address some anomalies. If there is a vitamin D deficiency or problems with thyroid, it can take a bit of time before those levels return to normal. But ideally, we're looking at, the NICE guidelines suggest a diagnosis within 4 months for adults and 3 months for children, so it is getting pretty tight. I mean, obviously there is going to be a period of debility following any kind of acute illness or viral illness. And maybe just some general advice in surgery is all that's required for it to resolve itself within a few weeks. But what we do know from the evidence, that if we can address the key symptoms as soon as possible, it can really help with reducing that severity and long-term morbidity of the condition. Interestingly enough, the ME Association did a poll a couple of years ago just to check how long it was taking for people to be diagnosed, and they discovered that 60% of their members had waited a year or more for diagnosis. The majority had waited between 2 and 5 years for that diagnosis. So how we tend to formulate the condition with people in our clinics is we talk about it in terms of the 3 Ps, being a 3-stage illness. So in the first column we talk about predisposing factors, and unfortunately there's still a lot that we don't know about this condition. Every month we get a list of the latest research from our library at the Warnford Hospital of all the research that's going on, but unfortunately there's still a lot of questions in terms of what's going on with the pathophysiology of this condition. So we talk about the fact that there's a lot that we don't know, but one day, hopefully, we will find a bit more. But we do know that there is a predisposing personality type to this condition. I used to work many years ago with Eleanor Feldman, who was a psychiatrist in our trust. She used to work for the Barnes unit and then worked in eating disorder. She used to work a lot with people with CFS-ME, and she said that she'd never met a lazy person with chronic fatigue syndrome ME. Lazy people just do not get this condition. And I think this is why the impact of this condition is so hard for people, because it forces them into a state of laziness or being perceived as lazy, which is the total antithesis of who they are. So I think it's creating quite an internal conflict within their core beliefs in CBT terms. So we talk about the predisposing factors, we talk about the precipitating factors, and this is the bit that we ascertain in our clinical history. You know, what led up to this? How were things before? Was there a precipitating viral infection? Was there a flu-like illness, glandular fever, something like that? Have there been particularly stressful events, emotional traumas, that kind of thing? Have they been recovering from surgery? Are they an athlete? Are they overtraining? What's their work schedule like? And any kind of, as we alluded to, any emotional distress or bereavement that they've been going through. And quite often with patients, it's a combination of factors that we're discovering are precipitating the onset of symptoms. And then the final section, which I talk to patients about being the bit that we're most interested in our clinics, is the perpetuating factors. So even though there's a lot that we don't know about this condition, what's keeping it going? What are the difficulties? What's happening? So we're looking at, the fact maybe people are over-resting as a result of these very debilitating symptoms, and then as a result there's some deconditioning happening. Or are people thinking about their predisposing factors? Are they pushing through? Are they ignoring symptoms? Are they refusing to rest and then just collapsing in a heap? Booming and busting, we call it. Are there fears and anxieties developing? Are they worried about exercising? Are they worried about making things worse, so therefore they're just not doing anything, avoiding? Thinking about their mood, because obviously there's been a lot of losses around developing this condition, maybe loss around their financial income, family relationships, that whole thing. Thinking about their diet. Are they attending to their diet, or are they just not having the energy or the motivation to look after themselves? And then thinking about their sleep, how that is at the moment, and whether they're resting too much during the day, or just the usual sleep hygiene things, looking at screens, especially with our adolescents, late into the night. So in terms of early management, what we're looking at is maybe not necessarily pharmacological intervention, but some things that could be helpful in terms of symptom management. So nausea is often a feature of the condition. Are there things like root ginger or those acupuncture pressure bands that might help? Maybe eating small, regular mouthfuls of food throughout the day. Are there more sort of natural pain things that they can be doing? Things like mindfulness that might help with pain. We also talk a lot about lifestyle modification, as I mentioned earlier, about some general sleep hygiene, what's helpful, what's not helpful. We talk about diet, grazing throughout the day, so rather than having 3 big meals and causing a big slump, it seems to take a lot of energy for our patients to digest a large meal. So maybe having 5 smaller meals throughout the day, making sure that they're drinking enough fluids, not too much caffeine, what their tolerance to alcohol is like. Usually they are very intolerant to alcohol and smoke and other toxins. Thinking about their employment. Do they need to be thinking about a period of time off work in which to have a period of convalescence or temporarily reduce their hours in order to then build things back up again? I've also put in pleasurable activity, because that's something that often gets skipped by a lot of these patients. With the limited energy that they've got, they tend to just focus on work and chores, whereas actually what we know, having permission to engage in those pleasurable fun activities can be really helpful in managing a long-term health condition. And then we talk a little bit about activity and energy management, how you might be using your energy, how you might pace it, how you might build in appropriate rest, and balancing those low energy activities with high energy activities. So you're not spending all day doing that boom and bust, spending all day doing a high level activity and then crashing as a result. I've included just a little bit on the pharmacological perspective. There is some further information from BACME, which is the British Association for CFSME, that talk about some of the other symptoms that might be helped pharmacologically, but pain seems to be the biggest feature with our patient groups. So sometimes a small dose amitriptyline can help, starting at 10 milligrams, although sometimes patients say that actually they can only tolerate 5 milligrams, and that seems to have an effect with them. If they're finding it particularly sedating, then sometimes imipramine or nortriptyline can be more beneficial. And then it goes on to talk about gabapentin and pregabalin if not responding. But there is more information, and I've included in the resources at the end if you wish to know more. It might be useful to say at this point that obviously there's quite a big overlap with fibromyalgia and CFSME, the symptoms often mimicking one another, and we tend to talk about it in terms of a spectrum, having fibromyalgia at one end and chronic fatigue at the other, and quite often people will fall somewhere within that, so there will be features of both. Okay. And then in terms of a referral to our service, Jen was very keen to know, when do I refer to your service, who do I refer to your service? And unfortunately, it is a little bit complex in Oxfordshire because there's quite a few of our services, or services that are providing support for people with CFSME. So I'll try and unpick the pathway a little bit. So we've got our service, which is for young people 14 and upwards, and primarily we are commissioned by the CCG for the more moderate to severe people with chronic fatigue syndrome, although we're finding that we're getting both mild, moderate and severe in our clinics. We also have the OUH fatigue service, which sits within the infectious diseases department, so that's Brian Angus and Monique Anderson, who are providing diagnostic assessments, and they've also got some therapy time for graded exercise therapy and CBT. I'm aware that at the moment the CBT list is 2 years for an appointment at the moment, so I think predominantly most people are going down the graded exercise therapy route. I'll go on to talk about our approach in a little bit more detail in a minute. But we've also got Talking Space Plus now, which I'm sure you're aware have a long-term condition section within them, and CFSME is a condition that they are working with. They tend to like people who have comorbid difficulties with depression and anxiety, so it may be that Talking Space Plus is an appropriate service. One of the things that I will say that we have set up within the last year is an MDT triage with our service, the OUH Physio and Talking Space Plus, where we talk about new assessments and actually decide on what might be the best pathway forward, because it is very complex, the pathways in Oxfordshire, what might be the best service. So patients, you may find that some of your patients, we are moving around the services in terms of what's most appropriate for them. I've also put in there the optimised pain management programme, because they work obviously with chronic pain, and sometimes those with a predominant fibromyalgia presentation may benefit more from their programmes, and as I understand it, they have both physio and psychological intervention there. And then finally I've put the complex needs service, because we are finding that we are getting few patients with comorbid difficulties with personality disorder, mainly borderline personality disorder or emotionally unstable personality disorder, which we are finding actually quite difficult to treat. I think they find our programmes and rehabilitative approach quite difficult. So it may be in that situation a more complex needs service might be more appropriate. So these are the fundamentals of our therapy and intervention. So as alluded to, we do offer a rehabilitative approach to restore some or all of patients' function that's been lost due to the condition. So we tend to focus on phases of therapy, and we'll use a broad range of treatment techniques depending on the needs of individuals. So within these components, within these phases, we might be introducing elements of CBT or graded exercise therapy or activity management. So it's very much depending upon the needs of the individual. So just very quickly, for example, in the regulation stage, we might be trying to minimise the post-exertional malaise, the boom and bust that people are experiencing. So we might be exploring what good quality rest means, and quite often patients will state that rest is a waste of time, or it's a bad thing, or I can't stop in the middle when I'm doing something. So we might explore this in a little bit more detail around the thoughts and behaviours, around their ideas around rest, to help them understand it perhaps in a different way. So therefore we might be looking at a CBT approach within the different stages of our therapy. And then very quickly, this is just a snapshot of our outcomes. So this is taken from the group, the Introduction to CFSME course that we run, which is a 4-session course, and we do 3 a year around the county in different locations. As you can see, our outcome measures are very positive from that course. I haven't got the data from our one-to-ones today, or our young people, but I just wanted to give you a snapshot of what people are reporting. And then finally, the top tips, the things that we've found beneficial or useful is the history taking. We spend an hour and a half with patients at the beginning, taking a full history and putting it into that formulation. Within that, we might start some therapy and setting people going, but I think people really value that time to tell their story, which kind of leads on to the belief acknowledgement of the impact of the condition. I think for a lot of people, they feel that no one is believing them, and as I alluded to before, that element of feeling lazy, just having that acknowledgement of what they're experiencing is real and valid. A prompt diagnosis and some initial symptom management. Patients will often be relieved once they receive a diagnosis from us. I think it's a useful starting point from which, or a springboard from which to start therapy, and a useful engagement. So patients will often say to me that they feel so relieved that they're not imagining it, they're not going mad, that what they are experiencing is something very, very real. I have put in there the verses of the danger of diagnosing those with personality disorder, because I think a lot of emotional distress can sometimes manifest itself in a very physical way. And I think sometimes adding those with a personality disorder are often seeking more diagnoses, and I think sometimes stepping back and looking more broadly about fatigue and what its causes are can be more helpful than labelling it. So I'm sorry I'm talking about a bit of a contradiction there, but it's sort of different in different patient groups. Giving a sense of hope and recovery. So in terms of prognosis, there are studies out there that suggest that 20% of people will make a full recovery from the condition. 60% will recover to some degree, to some extent. And we talk about recovery, not necessarily cure, but in terms of quality of life and participating in life. And unfortunately, there will be usually around about 20% that will not get any better and perhaps get worse. We talk about in clinics the unhelpful mind-body dualism, so rather than it being, it's not all in your head, it's not all in your body, but actually we are whole systems, and one will very much impact with the other. And just something that may be useful for you in your surgeries, that often this patient group are very susceptible to side effects of drugs, so often a baby dose is a good place to start with these people. And then finally, just some resources, both for you and for patients as well, things that you might be able to signpost them to.